Hi, so my name is Susan. I'm one of the agency nurses with Oregon Supported Living Program, and I am working with Nathan today. Nathan is a newly diagnosed diabetic, and so we are going to get a blood sugar reading for Nathan and give him his noontime insulin. So just want to make sure that we have all our stuff set out that we need. So I've washed my hands. Got gloves, have everything set up for the blood sugar, and I have his insulin ready. And on the computer, we've pulled up the orders, so I know how much to give. Alright, so first thing I do is I just kind of let Nathan decide which finger he'd like me to get his sugar from. Get that ready. Then we are going to load one of his test strips. And his glucometer. And as soon as I load it with the little chip part getting entered face up, it will get ready for a blood supply. Make sure his lancet is ready. In his lancet is a little needle that we change one time daily, and we have been keeping the setting on a depth of about 3, and that indicates how far the needle goes under the skin to get the blood. 5 is the max and 1 is the least amount. 3 has been working for Nathan. So he said, "You want me to use your index finger?" So first we're just gonna wipe the side of it. Do we have any tissue in here? I'm waiting for a piece of tissue. While I'm just gonna get the blood off of this. Blood on here. Let his finger dry for a second. Thank you. Okay, then I'm gonna make sure that it's pulled back and ready. I'm gonna hold it tight against his finger.
There it goes.
There it goes. Sorry, Nathan. I'm gonna push it. When you get a first drop of blood, you want to wipe that one away. And you will use the second drop of blood. Just touch the strip to it. And it's going to give you a reading. So right now it's saying he is 95. I note the time, it's 12:33. Make sure you're not bleeding anymore. Okay. I'm just going to...
Okay, so we're going to stop this video just for a few minutes to have a little bit of a discussion about what we know about diabetes mellitus and also the patient. So first we're going to swing down to the vitals and demographics. This is a 45-year-old male. He's just under 6 feet tall and he weighs 248 pounds. His vitals all look stable, no issues or concerns there. One thing that I would like you to do is put your hats on right now as if you are a provider. I saw that a lot of you are waiting to go to MA school, PA school, med school. Even if you're going into nursing school, put those professional caps on. And one thing that is very, very important as a clinician is to take a thorough history. Sometimes you can diagnose a person with whatever their issues are just by listening to a very thorough history. It's so important to listen to these patients. So we'll review the history. Nathan, recently diagnosed with diabetes. He was admitted to the hospital on 11/2017 with a high blood sugar reading of 860 on admission. 860 is really high. If you consider that a non-diabetic, generally we like to see their fasting glucose less than 126. 860 is significantly high. He was in the hospital for several days till they got his diabetes under control and was discharged with 2 types of insulin. We will be discussing insulin in just a few minutes. But as of right now, he's taking long-acting Lantus insulin once a day, as well as Humalog, which is a short-acting insulin before each meal. And very important to note, patient has a learning disability. So from a social perspective, he lived with his family until sometime in his 20s. Then he developed some issues with emotional and traumatic experiences and was moved into a state facility, transferred frequently to several different foster homes. And then after all of this, he was transferred to OSLP, is like an assisted living facility. And that was in 2014. Another thing that you can gain a lot of information about, if the patient does not know their medical history, you can take a look at their medicines. So the Lantus and Humalog, as we know, are new. However, he's also on Seroquel, which is known to have a side effect of raising blood sugar. And they did in the hospital lower his doses. Levothyroxine, famotidine. Levothyroxine indicates some type of thyroid disorder. Famotidine and Suprazole, they are indicative of some type of gastroesophageal reflux, upper GI issues. And then for his emotional and traumatic history, he's taking lithium, lorazepam, and carbamazepine, as well as the Seroquel. So also very important to note is communication and interaction. He communicates with a full vocabulary. However, he is limited in his ability to consistently communicate his wishes and expectations due to his mental illness. He has a good sense of humor, enjoys the company of select staff. He can be resistant to attending scheduled appointments and following daily routines. Now, this is extremely important, especially in someone that requires blood sugar testing multiple times a day, insulin administration multiple times a day, eating in relation to these medications multiple times a day. So when you have someone who has this type of history, it's important to know his social and communication and interaction history, and that he does work well with certain staff as well. So we're going to move down. We usually in medicine will have a differential diagnosis where there are multiple potential diagnoses that we could use. In this case, it was insulin resistance, type 2 diabetes mellitus, type 1 diabetes mellitus, Cushing syndrome, and hyperthyroidism. Those are some of the possibilities. No patient workup was provided, but we do know in his past medical history, as mentioned, post-traumatic stress disorder, schizophrenia, anxiety, depression, hypothyroidism, hypertension, hyperlipidemia, constipation, GERD with esophagitis, and obesity. So we will also scroll down very quickly just for some of the key points that they mentioned as well. They happen to know that their facility already provides a low blood sugar protocol. So they know that if Nathan's blood glucose level is less than 80 milligrams per deciliter, they are to institute that low blood sugar protocol. Each facility will have their own. Fortunately, he is in a facility. Many times patients are home alone. And that's one of the reasons it was important to show you the home situation, because you will go through all of your training, learning how to be amazing clinicians and providers. Usually it's in a hospital setting or some type of inpatient setting or a medical office. It's extremely important to think about how these patients are going to manage this on their own at home. So that's what we're going to focus on a lot today, in addition to the anatomy physiology piece. His long-acting insulin dose, the Lantus, is based on a sliding scale, and you will see this quite frequently with insulin. In his case, if he has fasting sugar levels greater than 140, they'll increase his Lantus by 3 units. If it's below 90, they'll decrease by 3 units. And if any of his sugar readings are below 70, they'll decrease the Lantus by 3 units. That's just one example of a sliding scale dose of insulin. You may have heard the nurse mention that she set the Lancet pen to a setting of 3. This is what she's referring to in terms of the depth of the needle that goes into his skin. You want to make sure that you can still get a drop of blood without squeezing that finger, and it's not too deep that the bleeding won't stop on its own. You don't want to be squeezing the fingers because these patients, they get multiple finger sticks each day, and they many times suffer from neuralgias, and this makes their fingers very, very sore. And then you have other patients that have needle phobias. So you really want to make the experience as positive and painless as possible. And you also may have noticed that she used the side of his finger and not right on the pads of the fingers. The pads are thicker because if you think about it, we touch a lot. Everything we touch is with the pads of our fingers. Therefore, they get thick and tougher to penetrate with a needle. So it's harder to get blood, and it also, again, can cause pain and bruising to the patient. So moving on, though, she did a really nice job with interacting with the patient, talking to him, keeping him calm, doing safety precautions, checking the needle, making sure that the blood was off the needle and cleaning it off, double checking the insulin dose, using a second person to verify. If you recall, she talked to the person that was recording the video to verify that dose. In most institutions, insulin is a drug that you will need a second person to verify the dose because it is one of those high risk medications that can cause death actually very quickly if you accidentally give the wrong dose. So we are all human, and that is why it is so important to always double check these high risk medications. Many hospitals and inpatient units have a policy regarding that. So please keep that in mind, even if you're working in a doctor's office and have to administer insulin or teach a patient how to administer his own insulin, to verify that dose because of the safety issues. Also mentions is that we must make sure prior to administering insulin that they are planning to eat, especially the short-acting insulin, which is what she was going to administer. She was going to administer him Humalog. Therefore, she asked him, "Are you planning to eat today?" And he verified, yes, he is planning to eat. You don't want to give that insulin if they are having nausea, vomiting, diarrhea. You may need to call the provider and hold that dose of insulin if they are not planning to eat, especially the short-acting insulin. Because again, giving that insulin can result in a severe hypoglycemia, and that is extremely dangerous. So I'm going to scroll back up to the video, but at this point, I'm going to stop sharing this screen and go to our PowerPoint. Okay. So we're going to be talking about diabetes in general. You can see that it is very complex diagnosis, and it requires multiple components of care. So just as a brief overview, this box up. Generally, when you hear about diabetes mellitus, you think about type 1 and type 2. There are other types, but they are usually related to medications, steroids. They're a real big factor in increasing your blood sugar. And as mentioned with his Seroquel, that's another medication where a side effect is to raise your blood sugar. There, it's important to know which medicines can raise the blood sugar. So that is one other type of diabetes, as well as gestational diabetes. Those are two that you might hear about. But for today's purposes, we're going to talk about type 1 and type 2. Those are the main ones that we hear about. So type 1 is an autoimmune disorder. It's where your body's immune system will attack the beta cells of the pancreas. The beta cells in your pancreas are what produce insulin. Therefore, once those cells are attacked, your pancreas can no longer produce insulin on its own. And insulin replacement is necessary for survival. You must have insulin replacement, as well as watch your diet. When you're talking about type 2 diabetes mellitus, there is an increased risk related to obesity, hypertension, genetics, certainly advancing age as we get older, and certain types of ethnicity. This is where your body, for some type of reason, something is triggered that causes your body to either reduce the insulin secretion or you develop insulin resistance, or both. When you have an intake of glucose, what happens is your organs normally absorb that glucose. Your body breaks down a carbohydrate, your organs absorb it and use that carbohydrate or that glucose as energy. What happens in type 2 diabetes is that your organs cannot absorb that because you're not producing insulin to help it cross over into the organs. They just cannot store the glucose. They don't absorb it, they don't store it, and it cannot be used as energy. And all of that glucose just continues to circulate in your bloodstream. Treatment options with type 2 diabetes mellitus, because of the insulin resistance, there are at times oral medications that they can prescribe for you. There is a combination many times of oral and injectable medications, including insulin, and there are several out on the market now. There's no way I can cover all the medications in this 1 hour webinar, but certainly there's something new every day. But you also not only need medications, but it's imperative that you have lifestyle changes and you manage those comorbidities. And if you recall, Nathan has a lot of these comorbidities. He is obese, he has hypertension, he has behavioral and emotional history that lends itself to having difficulty with managing any kind of stressors, or absorbing certain information as well. And this learning disability definitely impacts that. So moving on, so just to discuss hypoglycemia and hyperglycemia, again, very briefly, very overarching. Symptoms are usually hunger for hypoglycemia, hunger, irritability, trouble concentrating, fatigue, sweating, confusion, fast heartbeat. They can get very shaky and have terrible headaches. For hypoglycemic patients, you want to ensure that they are checking their glucose levels every 15 minutes. And while this is occurring, you must ensure that they are consuming fast-acting carbohydrates, and that is eating or drinking 15 grams minimum of a fast-acting carbohydrate. They can carry glucose tablets in their wallet or purse or pocket, anywhere. Fruit juice those are the best. There's also a glucose gel. Those are your best first line treatment options. If you have nothing else, a full sugar soft drink or some type of hard candy can be used as well. But the processed sugar is more difficult to break down than something like fructose that is present in natural fruit juice. I always tell my patients, carry those little, the juice boxes of the 100% natural juice with them at all times. Carry it in your purse, keep them in your car, keep them on your person at all times, because you've got to get that 15 minimum grams of fast-acting carbohydrates into your system. Then repeat this every 15 minutes. If that glucose remains low, you want to make sure that that glucose continues to rise and go in the right direction, because sometimes when they become hypoglycemic, they can just keep dropping very, very quickly, and then it is extremely dangerous and can be fatal. While this is going on, also have them eat a snack with protein and the carbs. Peanut butter crackers. I always tell my patients, carry peanut butter crackers wherever you go, especially if you're going to be in a situation where your next meal is not completely certain. Diabetics generally, once they are well controlled, they have a very specific schedule. They know when they need to take their medicines, when they need to eat, and when they need to take a snack. They must carry a snack. And like I said, peanut butter crackers is a great quick snack that has protein in it. That protein will, in combination with the carbohydrates, help to raise that blood sugar, but the protein and fats will help to maintain that blood sugar up until their next meal. But they must continue to check their blood sugars. And then also so important in patients who have issues with hypoglycemia or are on insulin in general, you must educate their peers. Make sure that everyone in their family, their friends circle, their social circle know what signs that patient exhibits when they start to drop their blood sugar. Once you get to know that person, you will notice, hey, she's talking funny. We need to have her check her blood sugar. Or she's getting confused, or she's getting so sweaty or shaky. Once your peers know, because again, if you are having trouble concentrating or you are getting confused, you may not have that mental capacity at that point to check your blood sugar. And you have to rely on someone in your social circle to help you with that. On the flip side, hyperglycemia is extreme thirst, dry mouth, weakness, headache, frequent urination, because your body is trying so hard to get rid of that extra glucose as fast as it can, blurry vision, nausea, confusion, and shortness of breath. Again, you want to continue to check your blood glucose levels, take that medication. Again, many times they are ordered sliding scale insulin so that if they know that their sugar is above a certain level, they may have that order to give themselves a few extra units to help bring it down. Very, very important is to hydrate. Have them drink water. That will help to flush out that excess glucose. If they are able to exercise, have them do a little physical activity. Jump on the treadmill for a couple minutes. That physical activity will help to lower those blood sugar levels. There is a caveat to that, however, if they are prone to producing ketones in their urine, then that is, you don't want them to be exercising. When they start to produce ketones, and that's the next sign, this is a sign of diabetic ketoacidosis, or DKA. You'll hear us refer to that as, but they will have nausea, vomiting. Their breath will smell very fruity or like acetone. It's a very distinct odor to their breath. They will also have abdominal pain. If this is the case, they need to seek medical attention right away. Many type 1 diabetics, this is how they actually present to us, and that's how they get diagnosed. So when that happens, most of them carry ketone strips with them that they can check their urine, and those are just over the counter. You can buy anywhere at pharmacies, and that will help you know if someone is in ketosis. They need medical attention if you're unable to recognize the other signs. So how do we diagnose it from a laboratory standpoint? As providers, we are going to draw quite a bit of lab work. The hemoglobin A1C is expressed in a percentage rate. This is the measure of someone's average glucose levels over the past 1 to 3 months. They do not need to fast. In fact, fasting is not necessarily going to affect this result at all, because it measures over 2 to 3 months, a period of 2 to 3 months. That's because it's measuring the hemoglobin. The hemoglobin is the protein that becomes covered with glucose. So we can see when someone's hemoglobin has higher amounts of glucose surrounding it in that hemoglobin A1C value. And the hemoglobin will regenerate every 3 months. And that's why we can see over a course of time that their blood sugars have been consistently, on average, high. And anyone with an A1C, if you can see the stars there, greater than 6.5%, that is generally an indicator of diabetes. A fasting plasma glucose test is obviously where performed once they have withheld from food and drink, except for water, for at least 8 hours. We try to schedule this one generally before breakfast because, again, these patients need to be on a very tight schedule with eating and taking their medicines. So if their fasting fasting plasma glucose is above or equal to 126 milligrams per deciliter, that is a red flag for being diabetic. One single test result with that is not always indicative, but it's certainly something that should alert us to probe further and perform other tests. But if it is consistently, you are seeing those fasting plasma glucose levels higher than 126, then there is a very good, strong possibility of that. And also an oral glucose tolerance test. This is where we have you drink a very, very sweet concentrated drink. We will check your blood sugar before you drink that. And then we'll have you drink this little concentration of, it's a compound of sugar sweeteners. And then in 2 hours, we will check your blood sugar again. If it is above 200, that's an indication of how well your body is processing sugar. So that is another test. And you'll see this quite frequently with pregnant women. We do this test usually around 24 to 26 weeks, I believe, just to test them for gestational diabetes. And if there's any question about it, we will pursue that further. There are also some other tests that can be done by your endocrinologist. They will check for autoantibodies in the blood as well as a C-peptide secretion. So that gets a little bit more in depth once you get to that point where you feel that they feel that you need to see an endocrinologist to explore this further. That is one of the ways they can differentiate between type 1 and type 2 diabetes. Other key characteristics, we'll go through these quite briefly because I want to make sure we have time for questions at the end. But as you can see, there's different onset. Type 1 used to be considered juvenile diabetes. That is no longer the case. We have seen it does generally start in childhood, but we're seeing it diagnosed into early adulthood as well now. Type 2 diabetes is generally, it used to be referred to as adult onset diabetes. However, we are seeing it now in adolescent children, usually not before age 10. So usually they are at least 10 years or older and in the adolescent phase into any period of adulthood. Type 1, females and males, it's equal distribution, whereas type 2, generally they see more females than males. Ethnicity is not necessarily a factor. However, we see it less in type 1 in Asian and Native Americans. In type 2, we generally see a little bit more in Hispanic, African American, and Native Americans. Obesity, not so much in type 1, but in type 2, that is a huge, huge risk factor. At least 90% of our type 2 diabetic patients are obese. And generally it is around the midsection because that adipose tissue that builds up, it just tends to infiltrate on that pancreas, again, putting pressure on those beta cells to either become resistant to insulin or to stop producing or begin to quit producing insulin. Onset of symptoms. This is also something that is very indicative of type 1. If you have an acute onset and they're saying weeks to a month, it comes on pretty quickly because once your body attacks those beta cells, it tends to happen very rapidly. Whereas type 2, it is a very slow, insidious onset. It goes undetected for a very long time. The symptoms are very vague. It is many times difficult to pick up on for sure until you start to exhibit symptoms. Another symptom that you may run across is acanthosis nigricans. It's very rare in type 1, but it is common in type 2, and that's like a darker discoloration of the skin, especially in skin folds like around the neck, the belly, under the breasts, many of the skin fold areas. It's a darker pigmentation. We talked about ketosis. Or diabetic ketoacidosis at onset. That's generally how we diagnose type 1s. However, now we are realizing that type 2 diabetics can also suffer from ketosis and become or present with diabetic ketoacidosis as well. Islet autoimmunity, we talked about being able to run tests that show autoantibodies. Your body will produce autoantibodies in type 1 because it is that autoimmune disorder where your body is attacking itself. It's attacking its own pancreas. Therefore, those autoantibodies will be present in your bloodstream. Whereas in type 2, generally, you don't see much of that being present. Initially, you will have some weight loss with both types just in the beginning. Just because your body is in that mode of that when you're not diagnosed, initially you may see a drop in weight, like a very quick weight loss. Again, the C-peptide secretion, you're not going to see that or see very little of it. You'll see actually low levels in the type 1s, but if it is high, it is usually also how they diagnose type 2 diabetes. And in type 1 diabetes, you will not have any insulin resistance because you're just not producing any. But you will have an increased insulin resistance in type 2 diabetes. Okay, we are going to stop here and go back to the presentation or the video to finish that out. So second till I get back to that. I don't see any questions in the chat. I hope I'm clear enough for you. And we will continue the video.
I'm gonna write that down. And then because Nathan's going to be eating lunch, so you are want to eat your lunch today?
Yeah.
Hungry? Okay.
Yeah.
So that means he can go ahead and get his insulin. So we've pulled up the order on the computer. And I'm just going to double check it. He's getting the Humalog, gets it 3 times a day. This one is for 1 p.m. and he is getting 8 units. So I want to make sure I grab the right insulin out, which is the Humalog. You want to always check the expiration date on it. Okay. And grab a new alcohol. I'm going to wipe the top. And you're going to grab one of the insulin pens. On the box of the needles, it has expiration date as well, and you want to make sure you've checked that. You're going to expose the needle, and then you're going to put it straight down onto the pin and then screw it on. Remove both caps. And then you're going to prime your needle, so you turn it up to 2, and you're going to squirt. Make sure you get insulin's coming out. That means your needle's primed. And then you're going to turn it up to the order, which is 8 units. You always want to make sure you have someone double check, so I'm asking the manager taping to double check the order.
That's good.
Okay, so then Nathan, where would you like your insulin?
Right here, fine.
So to administer insulin, you can use the back of the arms, you can use either side of the abdomen, the top of the thighs, or around on the hip area. Nathan wants me to use his arm.
Fine.
Let's wait. So you're going to clean the spot you're going to be injecting and let it air dry for a minute. I like to hold the pin where I can see the number. After the alcohol is dry, you're just going to go straight in at 90 degrees. Going to push down till the insulin pin reads 0 and then count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Just remove it straight out. And that's it. And then confirm that you're at 0.
Good.
All right, thank you. When you've already given the insulin, you don't want to risk getting poked by the needle. So we've been asking that staff put the cap inside the sharps, and then you can put the pin straight down. Use the container to twist it off so you're not having to touch the needle or risk poking yourself. And then just get the needle inside the sharps. And that's it.
Okay. Going to go right back into our PowerPoint. And that is the end of that video. So you were able to see the nurse administer the insulin. I just want to talk briefly. This does not cover even close to everything you will ever need to know about insulin management, but I just wanted to show you a little bit about how different these insulins are. You have your natural insulins, which are regular NPH, but then the majority of these are synthetic. You have your fast-acting insulins, which are Humalog, as he is using. Let's use that as an example. The reason she asked him if he was going to eat is that this has an onset of 10 to 15 minutes. It peaks within 15 minutes to 120 minutes, lasts less than 5 hours. So therefore, we want to make sure that once this starts to work, and that's what we mean by onset, it's going to start working within 10 to 15 minutes. He needs to have that first bite of food very, very soon because his sugar was 95. If he does not eat, that can drop his his blood sugar very quickly. Therefore, it's very important to have that. Now let's skip down to his Lantus. He has ordered Lantus once a day. This is a long-acting insulin. And if you can see it, I hope you can see my little arrow. The generic name is Glargine, the brand name is Lantus, but it begins to work within 2 to 4 hours, and there is no peak, meaning that this is going to remain constant within his body for a period of 20 to 24 hours it lasts. So that's why he was on a sliding scale when we talked in the beginning, that if his average fasting sugars are above a certain amount, we're going to increase this dose. If they're below a certain amount, we're going to decrease this dose. And those are some of the ways that we help to manage it. So again, that's why I wanted to show you how important it is to note these characteristics of the insulin in relation to meals activity, if they're going to go run errands or go work out, you want to reconsider when that dose of insulin is going to be given, because if they are very busy and active, keep in mind that that extra activity does tend to drop blood sugar levels. Will they eat at the same time? Will they have their crackers with them? Or I use crackers as an example, but will they have their snack with them? Will they have their fast-acting glucose carbohydrate source with them? And then again, sleeping habits. Some patients will drop their blood sugar severely in the middle of the night. It's called the dawn phenomenon. There are so many ways that we need to keep an eye on their blood sugars, as well as how much insulin they are taking, as well as how much activity they are doing, and their food intake. So we always ask patients to keep a food log or an activity log at least, and it will include all of those. But also important down at the bottom, please note, regimens must be individualized, will also depend on the type of diabetes, as well as consider that patient's degree of cognitive function, their living situation and support system. In Nathan's case, he has caregivers at his disposal, fortunately, that he can call on. But when you think about it, I want you to always think about your patients, what kind of situation they're going home to. Who is that support system? Do they have someone there with them should they need something? And consider that as you are ordering their medications. So let's, again, this is where I wanted to stop and take your comments. What other reasons would it be important to understand the characteristics, mechanism of action, and duration of insulin? We pretty much did cover that, but if you have any other comments or even any scenarios you'd like to share, please feel free to drop that into the chat. Also, what are some interventions that diabetic patients should consider when taking insulin? I know we covered that, but if anyone has any other ideas or scenarios they'd like to share, please feel free. I'll just give it a minute if anyone wants to add anything. So in the interest of time, we'll keep going, but if you have something you would like to add, please feel free to do so. I'm excited to see what your experiences are, as well as what your knowledge of this situation is. I can't imagine that there isn't someone who already has dealt with someone in their lives that isn't diabetic. It's pretty common. Especially with the obesity epidemic, the fact that, again, related to adolescents, they're finding that the food type that we are ingesting, how our food is made, the lifestyles that we are living these days, using fast food as our sources of nutrition and video games, as opposed to being physically active, that these have certainly contributed to the this epidemic. So something that I really want to talk about, and the reason we focused on the home health nurse video as opposed to any of the other videos, is something that we need to talk about is social determinants of health. You are going to see this talked about a lot, but maybe not in practice as much. And that's why I feel it's important to recognize. When we talk about the social determinants of health, we are talking about patients' environment, their economic, political, and social conditions. This is where people are born, where they grow, live, work, and socialize. This is shaped by the distribution of money, power, and resources. It affects health inequality and accessibility worldwide, and it heavily influences your diabetic treatment outcomes. Now, when we talk about those circumstances, we are talking about food insecurity, which means that they cannot consistently access affordable, nutritious food. Anyone who's been to the grocery store knows that the more healthy and nutritious food is, the more expensive it is. And that is quite a hardship on people. They are many times making decisions between, do I get medications? Do I pay my electric bill? Do I get nutritious information, nutritious food, or do I get something that is quick and easy because I'm so fatigued and I feel awful all the time because I have all of these health problems, and it's really difficult to cook a nutritious meal and also pay for it. Financial impact. Just as I mentioned, everything is so expensive, and they're already relying on medications, glucometer, the glucometer supplies, the little strips that go into your finger stick machine, the glucometer, those are a separate cost. Your needles, your syringes, everything is very expensive. So these poor people take a real hit financially. Increased risk for anxiety and depression, that can lead to non-compliance and poor self-care. There is a huge rate of non-compliance in diabetes management for obvious reasons. It's extremely complex. It's extremely expensive. It takes a lot of time. It takes a very dedicated lifestyle change that most of us don't want to do. And therefore, they're non-compliant either willfully or just unfortunately because of their social determinants of health. This leads to poor self-care. And then, of course, anxiety and depression. Why did this happen to me? All of my friends are going out and doing what they want and socializing and eating food on the menu that I really want to eat, but I can't eat because it's high in carbohydrates or whatever the case may be. This is very devastating diagnosis for people because it involves such a change in their lifestyle. And then something else that I also want you to really keep in mind every time you deal with a patient is their health literacy. Many patients, they get through the system, they live every day, but they actually have a diminished capacity to really obtain, process, and understand basic information. And then they have trouble making decisions about services and and any kind of health decisions that are necessary for them to survive. And I see a comment in the chat. I wanted to, Gianna, it is important to understand these aspects of insulin because you need to be aware of side effects of possible complications such as overinjecting. Absolutely. Duration is also important because for the best possible usage, you must time it with your meals. And someone in your family has type 1 diabetes, so you have seen that many highs and lows. It's scary, isn't it? Something that changes your lifestyle, but can definitely be managed and more understood over time. I completely agree with you, Gianna. Thank you so much for sharing that. All right, again, continue to drop your comments in the chat. I love to hear from you. So let's take a moment to stop and think about Nathan and the implications for him based on his social determinants of health. What do you think his health literacy level is? He has that learning disability, and he has a new diagnosis of a complex disease. Can Nathan recognize signs and symptoms of hypo or hyperglycemia to alert staff? Does he have consistent staff? It mentioned that he had some staff that he got along with well, and I would say that references the fact that maybe there are some that he doesn't get along well with. Will someone else recognize his symptoms of hypo or hyperglycemia? If he is very reserved, will they notice if he's getting confused or fatigued or some of the very subtle signs? Does Nathan understand how to rapidly treat his hypoglycemia to prevent a hypoglycemic crisis? That's all wrapped up in this health literacy. Consistent caregiver and residents. Fortunately for Nathan, it appears that he's been at this, we talked about his moving around to different foster homes. Fortunately, he's been at this one for the past 3 years. Does that mean he always will if he has another schizophrenic episode? It doesn't actually say what the circumstances were, but in assisted living, it can be something like a behavioral change or an ambulatory dysfunction or some type of circumstance that will cause him to require a different residence. So we have to look at, will this patient have consistent care? He has injectable medications that are ordered that are vital to managing his disease. So he is, with his learning disability, he is not going to be able to learn. And if you also noticed, he had resting tremors and intention tremors. That makes it almost impossible for someone to be able to dial up or draw up insulin and inject themselves with it. He may have limitations in mobility. We didn't see him walk, but given his circumstances, that's a very strong possibility. He is dependent on his meal choices and preparation. So therefore, those are some social determinants of health. And it's said that he had difficulty in keeping his appointments. So does he have someone helping him to manage his specialist follow-up? He needs that endocrinologist. He needs many other healthcare team members to help him manage this. So my question is, how can we as healthcare providers help these patients? So again, I ask you to share in the chat if you have some thoughts on this. When they are challenged with social determinants of health, what can we as providers do? We are so focused on, we don't want to be so focused on just the tests and getting them in and out of the hospital. That transition of care between inpatient into the outpatient realm is so vital. And I see and then something in the chat. Working alongside caseworkers. Absolutely, Ilya. You're exactly right. That is so important. And the first thing that we as healthcare providers and professionals must do is acknowledge our own personal bias. When we think that we're all, worried about equality and very sensitive to it, there are some self-help type of introspective tests that we can take where it's shocking to finally realize, oh, I think I do have a little bit of a bias. Maybe you work more with certain types of people or live around certain types of people and you're more comfortable in that area. That can create an internal bias that you just don't recognize. So it's very important to realize that you may have this and ensure that you are not providing differential treatment to patients from underserved populations. Make sure that we are acknowledging all of these patients. It's very humbling when you do a self introspective test and they are available on the internet because it's just something that we have to think about. We don't normally think that we have those biases. And again, just as Aaliyah mentioned, coordination of necessary healthcare services. It is paramount to managing diabetes in terms of scheduling appointments and tests, obtaining medications and supplies, paying medical bills, arranging transportation. Transportation is one of the leading factors in this country and actually globally that affects our ability and our accessibility to healthcare services. Diabetes self-care instructions are important to be at a patient's level of health literacy, and that may include multiple types of creative memory aids. You might have notebooks, alarms, calendars, visual cues, written instructions, anything that it's very important to, again, recognize that patient's living environment and who their support group is. This will help you determine the best way to instruct that patient as well as their support team. And then just briefly to let you know that diabetes takes a village. You need physicians, any type of advanced practice providers, nurse practitioners, PAs, etc., certified diabetes educators, registered dietitians, pharmacists, endocrinologists, care transition support, in other words, caseworkers, just like Aaliyah mentioned, a home health team, telemedicine, and specialists. And these specialists may include, but are not limited to, cardiovascular risk, gynecologic and obstetric care, neurology, nephrology, orthopedics, and podiatry, because remember, all of these comorbidities are not only present when they're diagnosed, they can get worse once if their blood sugar does not become regulated. Ophthalmology, they develop diabetes retinopathy, weight management, behavioral health. Again, we mentioned being depressed and anxious due to this new diagnosis. So I'm so sorry we're getting crunched on time. I am still going to quickly check the chat. As a provider, incorporate the time to educate the patients, provide the educational literacy they need, instruct them with written instructions and explanation. Absolutely, Tracy. Thank you so much for sharing that. It does, as I mentioned, it takes a village. It takes us taking the time to think about this patient as a person, ask them about their home care, ask them about their social situation. This is how we individualize their care plans for diabetes management. I'm going to stop sharing my screen.